uh, one. We're going ahead and recording now. So um, we are really happy to have you, Dr. Rosenberg. And if you want to go ahead and give yourself more of an introduction and start the presentation, then that would be wonderful. Thank you so much for being here.
Sure, and I appreciate your having me. Um, I always like working with Gilda's Club. So my name is Bill Rosenberg. I'm a neurosurgeon in Kansas City. I have been a spine surgeon for most of my career, and tonight I'm going to talk about various options for controlling cancer-related pain. I don't have a lot of disclosures that are relevant for this, except for a patient resource is a wonderful organization that publishes free information for cancer patients on a variety of subjects, and I help them create their cancer pain pamphlet. But while I have the disclosures on the screen, as I said, I was a spine surgeon, am a spine surgeon. And about 15 years ago, I decided what I was really interested in was pain, and a big part of that was cancer-related pain. And that started me on a journey that in which I founded the Center for the Relief of Pain here in Kansas City. And I've been involved in helping cancer patients with pain for that time, and started a organization called the Cancer Pain Research Consortium that's now an international charitable organization to bring providers together from all kinds of different disciplines so we can talk to each other and try to coordinate things. It comes as a surprise to many people that neurosurgery is really involved with pain. And but if one thinks about it, we were actually the original pain doctors. Before there was medication, opioids, things like that, there were neurosurgeons, and we would try to manage pain with various procedures. That fell by the wayside a little bit, and now actually is enjoying a resurgence as we discover that there might be more effective means of controlling pain than medications. We might be able to do away with side effects, and we're going to talk about some of those things. Before we dive into cancer-related pain, it's important to understand some of the nuances of pain itself, because not all pain is the same. There is a nociceptive pain, which is the kind of pain that we're all familiar with if we sprain an ankle, break a leg, things like that. That is the body telling us that something is very wrong and we should not run on that broken leg and we should let it heal. And that's pain. It's an adaptive response. Conversely, there's something called neuropathic pain. And that is when the nervous system has damage, peripheral nerves or spinal cord, and it actually is creating a maladaptive sensation. So that's where we get burning, pins and needles, things like that. And that can be a real problem because it does not reflect any external danger to us. It's all created, and we need to somehow manage it without necessarily removing some inciting event like fixing the broken leg. Visceral pain is yet another kind of pain, and that's the kind of pain we get from our organs, liver, intestines, prostate. So that's a yet another kind of pain. And the fact is, in many circumstances, it's a mixed variety. So there's some nociceptive, there's some neuropathic, and there may even be some visceral. And that's particularly true with cancer pain. So cancer pain is complicated, or can be complicated. And the fact is that there are different causes for pain during the cancer journey. About 2/3 of the time, pain is related to a direct effect of the tumor. It's pressing on a bone or destroying a bone or something like that. Oftentimes that's nociceptive, like that broken leg. although it can be mixed. If the tumor is, for instance, pressing on a nerve, that could have a neuropathic component. About a quarter of the time, the pain is related to something that we providers try to do to treat the tumor. That could be surgery, chemotherapy, radiation. Those things do cause damage. And if we damage the body, that can result in pain. And oftentimes, that kind of pain is neuropathic because, along with making an incision, giving radiation, we also can damage small nerves. And if those nerves are damaged in a certain way, they can create a painful sensation called neuropathic pain. And then about 1 in 10 times, we can't forget that, just because somebody has a tumor doesn't mean they can't have a herniated disc or, a bad knee or what have you. And so about 1 in 10 times, the pain is actually unrelated to the cancer. Another reason that cancer pain is difficult, it has to do with the interactions that patients often have with doctors. This has actually been well studied. There are a number of very large studies from places like MD Anderson, and we find that the communication between patient and provider is oftentimes the issue. There are sometimes that people feel afraid to report pain. They might be afraid that it represents a recurrence of tumor that they thought was gone, which may or may not be true. They may want to be able to be enrolled in a certain study, have an opportunity to get a certain treatment, and they might be afraid that if they had pain or they reported pain, they wouldn't be allowed to do that. Sometimes it's an issue of simply not having enough time during the visit. These days, providers are very rushed, and for various reasons. And sometimes, we kind of get people in and out, and we don't necessarily give them the opportunity to share with us what's going on. And then some people, we find, kind of assume that they're going to have pain because they have cancer. And they take it as a simple, normal state of affairs without necessarily reporting it and giving us some opportunity to help them, perhaps with things that of which they were unaware. And in terms of treatment, we need to, just like any other problem that a person might have from a healthcare standpoint, we need to consider a lot of different factors. We need to consider where the patient is in the cancer journey, what might be hurting, and also what are the goals in terms of continuing chemotherapy or being at home independently or being able to be with family and friends for an extended period without being overly lethargic, for instance. So all of these things need to be considered when we encounter somebody with cancer-related pain, to come up with some kind of a treatment plan. And really, if you break down what we do, there's only a few different kinds of buckets of treatments that we do. We can modify the source of the pain. We can treat the tumor, for instance. We can take it out or give radiation or chemotherapy or some such thing. Later on, we're going to talk about doing spinal fixation. That's a way of modifying the source. We take the pressure off of that weak area, for instance. We can also block the transmission. So between where the pain is being generated and where it's being experienced in the brain, we can block that. That's what opioids do, medications. They change that transmission of pain from where it's being generated to where it's being felt. We can do that with various surgical techniques that we're going to talk about. We can also alter the central perception, how that pain is perceived in the brain. We can change that. Again, some medications do that, some procedures, but those are the big buckets. And then we can talk about the details of how we might accomplish that. I'm not going to talk tonight about the medication side. Obviously, there's lots of medications that can be used. They have many benefits. They have some downsides. side effects, for instance, and things like that. But that is, although we do a lot of that, that's the subject of tonight is really what we have to offer from a neurosurgical standpoint. But obviously, those things would be incorporated into an overall treatment plan that probably would include some kind of medication, or often does. So, what are these procedures that we neurosurgeons can do to help manage, control? I'm not a big fan of the word manage, but control cancer-related pain. And those also have some general categories. We can, and they kind of parallel the categories I talked about. We can directly intervene at the site of the tumor. And oftentimes in, excuse me, in neurosurgery, that means, for instance, a spine tumor. And we might be able to stabilize that tumor. And oftentimes a spine tumor is kind of like a fracture. And if we can stabilize it, we can many times help with the pain. Conversely, we can also go in, and we're going to talk about all these things, and we can actually ablate, remove the tumor from a minimally invasive standpoint. We can change how that pain is transmitted, and that's called, in neurosurgery, that's called neuromodulation. We can change how that signal is transmitted. And with neuroablation, we can change not only how the signal is transmitted, but how it's perceived in the brain. So to start with spinal stabilization, we can often, as I said, a tumor is like a fracture. It's just a fracture that doesn't really heal. So a lot of times we can go in and stabilize the spine surgically, but we can also do what's called a vertebroplasty or kyphoplasty. And what that involves is, here we have a picture of a fracture, and this could easily be a tumor. And we can, through a needle incision in the back, either under general anesthesia or sometimes under local or spinal anesthesia, we can put a balloon into this vertebral body and expand it. And that creates a cavity, and it also restores the height. And then we can fill that balloon with cement that's left behind, and that stabilizes it. And oftentimes that is done for pain and can be very successful. It's an outpatient procedure. And we need to, when we talked about a treatment plan and considering all of the factors, we obviously need to do procedures that make sense in the clinical context. We don't want to have somebody come into the hospital for a huge operation when that doesn't make sense with where they are. So this kind of procedure will often make sense because it's an outpatient procedure. With spine surgery, the fact is that with many innovations, this has gotten smaller and smaller, and often can make sense as well. With image guidance, we now have essentially a GPS of the spine. And so we can make much smaller incisions and stabilize things, or even put screws and rods through the skin, just with percutaneously. I had a man who had a vertebral body metastasis that was very painful and had a very difficult time. And every time the body loaded on it, it hurt. And he had some health issues, other health issues. So under spinal anesthesia, with him awake, we made some small incisions in the skin, put in some screws and a couple of rods through those incisions, and we were able to get the load off of that vertebral body that was so painful. And he was able to walk out of the hospital. One of the innovations that just came about that I'm very excited about is this radiolucent spinal fixation. So now, in the past, we would put in titanium. And as far as treatment and follow-up, that could be problematic, because if it's titanium, the radiation oncologists don't like it so much because they can't send radiation through it. And also it can mess with follow-up imaging. So we now have these carbon fiber implants. They're actually made instead of metal of carbon fiber. And you can see here, this is what the screws actually look like, but on the X-ray, they basically disappear. There's actually a plate and some spacers in here, but you don't even see them because it's all carbon fiber. And you can see on this CAT scan, this screw here is made out of metal, and you can see how white it is, and it sends all of the scatter. And this one is made out of carbon fiber. So we're very excited about this. Our radiation oncology colleagues are very excited about this because we can treat better and we can follow the tumor better. To get to the point where we talk about directly addressing the tumor itself, there's a technology now called OsteoCool made by Medtronic, where, again, outpatient procedure with a small little stab incision in the skin, we can put these instruments down into the vertebral body where there's a tumor. In fact, we can do it in a number of locations and any kind of bony tumor. And we can, using radio frequency, we can ablate this tumor. We can basically dissolve it, burn it away. And then we oftentimes will fill up that cavity with that bone cement so we can get rid of the tumor and we can stabilize the spine. And that is shown to be very effective with controlling pain. This can often be complementary with radiation therapy. Oftentimes, radiation therapy will be given to tumors in bone, but it can take a while to take effect. And sometimes it doesn't help with the pain, or it takes a long time. So that we can do both of these and coordinate and get the pain relief early, get the benefit of the radiation, and often reduce the tumor burden with the radiofrequency ablation. So now I'm going to shift to that neuromodulation. And that's where we change how the pain is transmitted to the brain. And the workhorse of this in neurosurgery and actually in pain medicine as well is what's called targeted drug delivery. And many people will call this the pain pump. So this is a pump that's implanted under the skin. It's about the size of a hockey puck. And it's under the skin. And you can see that there's so this is in the front, in the abdomen. And there's a little catheter that's tunneled under the skin and up into the spine next to the spinal cord in the spinal fluid. And it goes all the way up like that. And that's put in under anesthesia with two small incisions, one in the front, one in the back, with a little spinal tap. And that can be done for really any regional pain. And by regional, I mean not whole body pain. We're going to talk a little bit later if there's an issue with basically everywhere or almost everywhere. But if there's a region, like the chest, the arm, leg, back, pelvis, then we can often get excellent control, because what we can do is we can deliver a microscopic amount of medication directly to the spinal cord. And that eliminates all of the side effects and makes it much more effective. And in fact, we can also deliver other medications that we can't deliver any other way, such as local anesthetic. And so we can often get rid of these unacceptable systemic toxicities like lethargy, constipation, loss of appetite, all of these nausea, vomiting. And we can do it even more effectively. In fact, we can sometimes put this in, excuse me, if we have anticipated needs. Sometimes when patients are referred to me, they have perhaps a certain situation where they don't have a lot of pain at that moment, but that we're anticipating with treatment and what have you, that the pain is going to get worse. And we can get this in, and once it's in and healed, then we have a very powerful tool that we can continue to use, because it's scalable, which means that we can adjust the dose. In fact, you can adjust the dose wirelessly. You don't even have to take your shirt off. So we can adjust the dose, and we often give patients a button where they can give themselves extra if they need it. It's flexible. We can try different medications. We can try this medication. If that's not work, we can add one or try a different one. We can often add medications for nausea, for instance, in addition to pain. It's also reversible. If the day should come when it's no longer needed, we can take it out. And that's, other than the scar, that's it. So this is a very, very powerful tool we have that is very effective for cancer-related pain. As I say, usually I have people spend the night when they first have it, 30, 45 minutes to incision, very little risk. And there's some, but there's very little. It is MRI compatible, so it doesn't interfere with any imaging or anything like that. We do need to consider certain things, such as what kind of chemotherapy is being given and how does that relate to wound healing? Do we need a window off of that? Where is radiation being given and where should we put this pump? And there's a lot of options for that. Things like blood thinners, we need to make sure that we're on top of that. And if there's an ongoing infection, we need to be very careful that we don't put this in and have it get infected. But we do have some excellent multi-center data on the efficacy of this. And it's not only is it very effective in terms of getting rid of pain, but we find that the toxicity is much lower. And what that translates into is an actual survival advantage of this patient population, which means that we have data to show that getting pain under control not only is important for quality of life, but also can be important in terms of longevity. I'll give you a moment to read this. This is one of my patients who had pancreatic cancer. All of these are, by the way, with permission. So we put a pain pump in her, and she had a goal of she wanted to go to Hawaii and walk on the beach, and we got her there, and she was very happy about that. So this is an example of someone using targeted drug delivery. Another patient of mine had horrible pain from vulvar carcinoma. And you can read some of her comments there. She particularly liked the button that we gave called patient controlled delivery. We gave her that button and she could, if she felt like she had an extra need or there was some breakthrough pain, she could control it. So this is just a couple of examples of patients of mine. In fact, one specific example of this is if somebody is perhaps nearing the end of their life and they really maybe just want to take care of some things with their family, spend time together, maybe even for a few weeks, but they're in horrible pain and the choices are to give them a lot of pain medicine and basically make them, unresponsive or very lethargic. We can sometimes just put the catheter in and the pump can be on a pole next to the bed or something like that. And we can get control that way without even having to have a surgery in the hospital, for instance. So this is a very powerful tool with a lot of flexibility that we use fairly frequently. I'm not going to spend a lot of time on neurostimulation, but it does have a role. Neurostimulation, we understand that particularly for neuropathic pain, if we apply a small electrical current to various parts of the nervous system, we can really improve that pain. We use this a lot for non-malignant neuropathic pain, like people who've had back surgeries and still have pain and things like that. This is best though, since it's not scalable, we can't like increase the dose or change the position. It's really best for a stable pain syndrome. And where this really shines is in an area called survivorship. So once the cancer has been treated and we feel like things are in remission, sometimes people will have pain from the things we do to them. They might have, as we talked about, post-surgical pain after a mastectomy or a thoracotomy. or an amputation. They may have chemotherapy-induced pain from damage to the nerves. Same with radiation. And we can frequently get control of that with very small outpatient procedures, some of which are done while awake, some are under a brief anesthetic, all of which are outpatient, and really quite effective. So this is a small area, but an important area where we can help with pain. Now we'll go on to what's called neuroablation, which are what neurosurgeons can do to influence pain. These are really the original pain procedures before there were pain medicine and before there was pain doctors. Many of them, although they sound very big, they're really not from a neurosurgical standpoint. Many are outpatient, minimally invasive, often under local anesthetic. This is actually a partial list of the things we do, and I'm not going to talk about all of them. I'm going to pick a couple that are really important. If anyone has any questions about something specifically, I'm happy to answer it at the end of the talk. But one of the big things we can do is what's called a chordotomy. And that's where we can take under local anesthetic in the CAT scanner as an outpatient. We can take a needle and after numbing things up, we put the needle in and we can find the pain fibers in the spinal cord and shut them off. And it's exceedingly prospective. We do a myelogram ahead of time, and you can see this is the position here, and this is the needle that we put in after numbing up the skin here. And you can see this is a CAT scan, and the front's here and the back's here, and this is the spinal cord floating in spinal fluid, which is white because we did a myelogram. And you can see the needle coming in here, and there's a little probe right here that goes in, and we actually put that in, and we can verify. We turn it on. People say, "Oh, I have a funny feeling, and it's over here," and we get to the right area of the pain, and then we shut the fibers off, and we can get almost instantaneous relief, like turning a switch off. For severe pain, we often do it for chest wall pain, hip pain, arm pain, really, any pain that will localize to an area as opposed to whole body. This actually is well studied. We have lots of papers on it. You can see that there are over 3,500 patients that have been reported. We don't have any meta-analyses or class 1 studies. Those are very difficult in surgery. But we get excellent control with this technique. And I wanted to tell you about one of my patients. He's a 30-year-old man, and he had a spontaneous fracture of his femur. He was going to work and gets out of his truck, and his leg breaks. And he goes to the hospital, and he's diagnosed with a large tumor of the femur. And you can see this whole thing. This is a thigh MRI. This whole thing is tumor. And it was so painful that he would only get out of bed for doctor's appointments. It was inoperable, unfortunately, but he would only get out of bed for doctor's appointments. And he was on very high dose intravenous continuous Dilaudid with bad pain. And I saw him, we talked about his options, and this is where we talk about where the patient is. What are his interests? He's on chemotherapy. He wanted to stay on chemotherapy. He didn't want to come off for anything. So we talked about maybe a chordotomy instead of a pump. And so he came in and had his chordotomy, and you can see the needle placement right there. That's a CAT scan. And he had immediate pain relief and walked out of the hospital on his own 2 legs. And he, after we weaned him off, he eventually wound up on no pain medication. And these are his words on what his life was like before and what the procedure was like. And he was pain-free for the remainder of his life. A similar but not identical procedure is called a myelotomy. And that's, remember, we talked about visceral pain from the organs. And so that's a different pain pathway, but we can interrupt that like we do with the cordotomy. There's a couple of different ways to do that. Some is open with a small surgery, and some are with a needle. And this here is a picture of that open procedure. This is under the microscope. This is the spinal cord here. And the spinal cord, this whole distance from here to here is about the width of a thumb. And then you can see the instrument here is disrupting these fibers that are traveling to the viscera, the abdomen. And that's an open procedure. Conversely, this is a case of a percutaneous procedure. So here's our myelogram. You can see the spinal cord here. Patients actually face down. So the nose is here and the back of the head is here. And you can see the needle coming in here with the probe right on the top. And so this is a woman who had a recurrent pancreatic cancer, and she was on very high doses of opioids. So we talk about morphine equivalents, and she took between 180 and 300 milligrams of morphine a day, still having horrible pain. And after this procedure, we had her down to 10 to 20 milligrams of morphine a day with good pain control. Lastly, I'm going to talk about hypophysectomy, and this is an odd one. This is actually taking out the pituitary gland, and it's been done for many, many years, coming up 70 some years. And we originally thought it had to do with hormones, and maybe it was breast and prostate. It turns out it's not. It's really for bony metastatic pain. Any pain from metastases to bone can be responsive to hypophysectomy. And we used to do it as an open procedure. It's a small open procedure, but there are some very large studies. You can see over 200 women in this breast cancer study, combined of almost 80 men in this prostate cancer study. So it can be exceedingly effective. Now we can do it with radiation. So this is a radiosurgical procedure, which means it's done with radiation as an outpatient. And basically you lie in the gantry, do the radiation. It's a one-time visit, and then that's done. And there are some not big studies, but good data. This is looking at the treatment plan for the radiation to the pituitary. I had a patient, and this was a patient when we talked about whole body pain. So this is a man, 80-year-old man, who had prostate metastases really throughout his body. This was not going to be amenable to a pump or anything that was regional, because it was really everywhere, and it was horrible pain. And you can see he was on over 500 milligrams of morphine a day with 10 out of 10 pain. And he came in. This is a picture of his femur with all of his metastases. He came in and he had a radiosurgical hypophysectomy, a one-time visit, took an hour, hour and a half, had lunch, went home. And over the next several days, he went from this situation to 200 milligrams of morphine a day, but with excellent pain control, 2 out of 10 pain. And this continued to drop for the remainder of his life. So that's another very powerful tool that we can use to help with pain control. And to kind of bring it all together, I wanted to talk about this man, 71 years old. He had a lung cancer. He had really bad upper chest pain. And we put in a pain pump, and we got great control of his upper chest pain from his lung cancer. But he also had this metastasis to his sacrum, and he couldn't sit up. Every time he tried to bear weight on his sacrum, even with the pump in, because it was all the way up here with this region, he couldn't sit up. It was unbearable. And he was in the hospital for a long time before we were called back to him. And what we did is we went and did a small surgery. This actually is the catheter of the pump that we moved aside. And we did a myelotomy for this sacral pain. And he was immediately able to ambulate, sit in the chair. And after 2 months in the hospital in pain, within a few days, he was able to go home without pain. So I think in summary, cancer pain can and should be treated aggressively. The goal should be the best possible pain relief with the lowest risk and toxicity. And that's important because sometimes people say, well, I can get my patient out of pain, I can give them a lot of pain medicine, but that's not necessarily the best quality of life, the lowest toxicity. It's also really important to communicate with your providers honestly and completely about pain. That's the only way we're going to know what's going on and what we might be able to help you with. There are a lot of strategies. We got a big toolbox to deal with pain. It's not just pain medicine. And I believe, and I mean, many people believe that everyone who's on a cancer journey has the right to have at least one provider continuously assessing their pain control, their quality of life, looking for opportunities to improve that quality of life. And it's not just a one-shot deal. It's, oh, great, we have it under control today. Maybe that won't be the case next week. Then we need to reevaluate. Is there something else we should be doing? So thank you for listening. And I'm happy to answer any questions.